Welcome to the other side of Lucy Letby. In episode 24, we're going to finish off baby E. Sadly, we will never know what baby E died from specifically. Going back to baby E's mother's statement, she had been expected to give birth in Liverpool Women's Hospital, but due to capacity reasons was taken to the Countess of Chester Hospital. And remember that she had likely intrauterine growth restricted identical twins. The fact that there was no capacity at Liverpool Women's Hospital was not a medical decision, it's a political decision. And the Countess of Chester Hospital was never a suitable place to take care of this very complex pregnancy. We all know from the RC-PCH report that they didn't even have a separate roster for neonatal care. We also know that baby E was born on the 29th of July 2015, 1.327 kilos, which would put the gestation in around 30 weeks. There is very little evidence available for the care of baby E. The evidence from the only source I can find, which is the Total Life wiki. We have the mum's statement that says in this wiki that the mum walked to the incubator to see blood coming out of baby E's mouth and panicked as she believed that something was wrong, and that Lucy Letby was at the workstation at the time, the mum tells the court. She said she heard crying, a sound which shouldn't come from a tiny baby. I can't explain what the sound was. Horrendous. It was screaming more than crying. She said she heard it in the corridor in the unit itself and entered the unit through the door where the twins were. She said she was in that room for about 10 minutes. She said there was blood on his face, around his mouth. She tells the court she was asked by police to draw on a drawing of a child's face where the blood was coming from. She tells the court the blood was coming around the mouth. Nicholas Johnson KC says it is almost like a goatee beard. The judge asked for clarification and the mum says there was a little above the lips, but mostly below. The mum said she asked Lucy Letby why baby E was bleeding and what was wrong. She said Letby replied the feeding tube was rubbing on the back of the throat and that would have caused the blood. The mum said she accepted that explanation, but was concerned about it. The mum said Letby told her to go back to the ward, and she did what she was told as Letby was an authority and knew better than me, and I trusted her completely. She said that the registrar was on his way, and if there was a problem, someone would ring up to the postnatal ward. She said she accepted that explanation and returned to the postnatal ward. Upon her return, she rang her husband as she knew there was something very wrong. The court hears that the telephone records, including timings, were obtained, and the call to her husband was made at 9:11 p.m, but only lasted 4 minutes and 25 seconds. Then we go to Ben Meyer's cross-examination, and he expresses his sympathy for what it's worth, for what the mum has gone through, and says that nothing he says will seek to minimise anything the mum did in caring for her twins. The mum is asked if any of the times she said to the court were not correct on her recollection, given she made the statement to police 2 years after the event. The mum confirms the time she went to the neonatal unit on August 3rd, 2015 was correct. Mr. Myers suggested mum went down at about 8 p.m. at the time of the handover and went down at about 10 p.m. with the breast milk and went again when baby E was being resuscitated. And the mum said that she absolutely disagreed with that. Mr. Myers says for the supposed 9 p.m. time, the observations were the screaming and the blood coming out of baby E's mouth. And the mum agrees. Mr. Myers asks for the crying. There were other staff about at the time. At no time did any other staff come into the room, did they? And the mother says no. And Mr. Myers suggested the screaming was not as bad as that. Horrendous. The mum said it was horrendous. Any noise that a baby's making in distress is going to be horrendous for a mum. Mr. Myers asks about the blood scene. The mum says, other than around the chin, the other blood scene was above the lip, and no blood anywhere else. And the blood was not coming out or going on the bedding. The mum agrees in her statement the blood was not fresh. The mum says and nods it was blood. This is slightly at odds with the baby actively bleeding. Also the mother's evidence to the prosecutor as well as to the defence does not indicate that whatever time it was that she went, around about 9 o'clock, that the baby was not actually bleeding or actively bleeding, but had signs of old blood, as she says herself, on his face, indicating that bleeding had happened. So the problem that we have here is that we really don't have a lot of descriptive evidence of active bleeding around 9 o'clock. But we have some evidence upper gastrointestinal bleeding had already started. There are studies that show that one big study with 984 patients had an incidence of 9.4% of bleeding. So if we go through the complications of nasogastric tubes, which are spoken about frequently but are not without risks, like every procedure in medicine. So they have high rates of bacterial contamination and they increase the risk of sepsis and necrotizing due to the bacterial colonization and this biofilm problem forming on the tubes. Frequently nasal bleeding and mucosal line due to the NG tube insertion and feeding intolerance. So even though you're using these things to give babies food, they can lead to feeding intolerance in themselves. So it's possible that disturbance of the nasogastric tube caused old blood to be present on the night that the mum went, on the night of the 3rd of August. That's absolutely possible. There was no active bleeding at the time, that whatever time it was that she encountered Lucy Letby. In terms of the baby screaming, I think any mother who hears a baby crying or in distress is going to refer to it as horrendous, because it is horrendous. But it's interesting that the crying characteristics of preterm neonates are totally different than that of term babies. That's due to a thing called the fundamental frequency. So if you play an A note, middle A note on a piano at 440 hertz, so that's 440 times per second that this string is vibrating, and that's the fundamental frequency. But you multiply that fundamental frequency by 2 and you get what's called the harmonics, and they just carry on infinitely until above 20,000 hertz when humans can't hear them anymore. And this is what gives an instrument its timbre, why you can separate one 440 hertz frequency from another. And preterm babies have a much higher fundamental frequency. than term babies, and that's mainly to do with the vagus nerve, which influences the cord focal tension and the pitch in these babies, and the nerve is not as developed as it would be in a term baby, and it becomes more developed around about 32 weeks and beyond. And the cry of a preterm baby would be very different. So basically, if the fundamental frequency is high, it's going to sound more like a scream. But what is causing the baby to cry is probably just the same reasons that any baby would cry. It's just a sound that's different. So preterm babies can also produce what are called protophones, and they emerge in early infancy, even in preterm neonates and the neonatal intensive care wards. And they're a form of early vocalization, and they include a wide variety of sounds, like squeals and growls, vowel-like sounds, which can be perceived as scream-like due to their high-pitch frequency because of this problem with the fundamental frequency being higher. So there is an explanation for what the mother heard. I don't tend to discount practically anything that a mother would tell me. But the mother left Lucy Letby around 9 o'clock, and she called her husband. So I don't understand that in terms of someone who thinks that a nurse is attacking their child. So like Ben Meyer said, I don't want to add distress to the mother. I believe that she heard what she heard, and that it definitely meant more to her than it would to other people who are used to hearing these types of sounds. And that she did see dry blood on the face of her baby. I don't doubt those things. But we have to remember that Letby has just come on shift. In this particular unit, they do very long handovers. She has got twins to deal with. She has a lot of work to do in that early stage of the shift. And if she's not overly concerned, she may have been brusque or dismissive. I don't know. I don't think anybody can know. There's no real way of knowing this. But the mother's description of scream as her perception, and the mother's observation of dried blood around the site of a nasogastric tube are perfectly acceptable observations and interpretations by a mother who's not experienced at looking at these things. But do they indicate that Letby had attacked or had been interrupted attacking a baby? Absolutely not. They don't indicate that at all. Certainly not to me. The other thing that is disturbing to me about this case is, again, this whole stability thing. You know, this is a stable baby doing really well. But this stable baby is now on day 4 of life. It's still on an nasogastric tube, and it's still taking very small feeds. And we know that in baby E, that there's still a long line and there's still a peripheral lining. Instead of saying that this baby was tolerating feeding well, the baby was not tolerating feeding well. And even in one of the text communications with Letby, one of her colleagues said that baby A had never fed well. So somebody else corroborated what I'm saying now, that the baby did not really progress with feeding as much as you would have liked. So I think that these things just indicate the baby was, again, not as stable and well as the prosecution want the jury to believe. These are complicated matters. We're also missing an awful lot of medical data, particularly around nitrogen in the body. And I don't mean Professor Kinsey's nitrogen that is going into hemoglobin. No, I'm talking about proteins. So is the baby in a catabolic state? Is it consuming itself to stay alive? In other words, is it destroying tissue rather than building tissue? there are ways of knowing that, and we don't know any of that. We don't know what the electrolytes were on this baby. We don't know what the blood urea nitrogen is, which is an indication of protein metabolism in the body. We don't know any of that stuff. And again, we should know that, or the defence should have been able to look at all of that and put together a picture of just how well or not baby E was really doing. Still requiring respiratory support, still not stable, because you see that from time to time, even on the 3rd of August, the oxygen requirements change. That's not stable. And we've seen frequently in this trial the prosecution changing what medics would regard as stable to what lawyers or prosecutors refer to as stable trends. A trend can be your friend until it isn't. And the suddenness with which these trends can change is really alarming if you've ever been witness to such incidences like this. So we have a baby, as far as I'm concerned, that I think would have done, sadly, for the family, would have done quite well in Liverpool Women's Hospital, but hadn't the snowball chance in this hospital because of the filth of the place and the lack of a dedicated neonatology staff. The whole place was just horribly substandard. Also, no indication here as to whether the baby was given vitamin K. Now, vitamin K is used to activate the clotting factors, just to keep it simple, and some babies will need more than others, but there's no indication that it was given. I don't see any reason why it wasn't given, but again, there isn't any information about that. And all the time that during the so-called kangaroo care that the baby was having, the baby was still requiring supplemental oxygen. We take all those things away, and this is not good. And then we get to the hyperglycemia. Unnamed nurse, and she's saying that she discovered it on August 3rd in a blood gas reading. So that would have been a capillary blood gas reading. And she found it to be 18.4. That was the blood glucose reading, which is particularly high. And so we look at the limitations again of capillary readings. They're okay for acidity, pH, and probably carbon dioxide as well. Oxygen measurements are less reliable again and can really underestimate the actual oxygenation of the baby. So they're not that useful for assessing the oxygenation status, and also oximetry is not really accurate at doing that either. The reliability of capillary blood gases as surrogates, I suppose, for arterial blood gases is not consistently established by different studies. An umbilical arterial artery would be much, much better. Capillary blood gases, again, are not really that effective in measuring blood glucose because they can be affected by things like the hematocrit level, which is the amount of red cells available. And they can lead to falsely elevated glucose values, and they can also miss hypoglycemia. So again, in terms of trying to look after very vulnerable babies, they're not accurate enough, particularly when you get levels that are too low. If you get levels that are too low, you have to validate them by another method. But we'll talk more about glucose in the case of baby F. So you can see a lot of complexity, a lot of uncertainty, a lot of missing information, medical information that could have been questioned by the defence. I cannot see any case for this argument that having a defence medical experts, neonatal experts, would have been detrimental to Letby. I just think it's lawyer talk. It's absolute nonsense. And I've no doubt that now that she has a new legal team with Mark MacDonald. I think we'll get answers to a lot of these things now, because he's going to have to get, I presume, his hands on all of this information, and he will get expert help in deciphering what is not in these records. And we're not going to speculate too much more on it. I'm just giving a generalist opinion, general scientific view of the complexities of these issues. So we're going to look then, just to finish this off, from the cautious feeding regime, which is another word for food intolerance, from the high glucose levels, the ongoing respiratory problems, a pH reading of 7.29, again on the 3rd. We don't know if it's respiratory acidic or metabolic acidic or mixed. We don't know, because we don't have that information. But we get to the evidence again of Dr. David Harkness, and we'll end this on this. This was the night that baby E died, sadly. So Dr. Harkness is a paediatric registrar at the Countess of Chester Hospital in the summer of 2015, and he's asked about baby E on the night of August the 3rd. So that's going into August the 4th. He says they started the shift about 8:30 to 9. So 8:30 to 9. So he's already, I don't know what time he started the shift at. He explains, with working with different hospitals, it's difficult to remember the shift patterns. There you go. He explains that there would have been a handover period, and where he would have read a handover sheet for the various patients and any outstanding conditions those patients had. And there would be one sheet for the paediatric ward and another one for the neonatal ward. If there was a sick baby in A&E, the doctors would have been responsible for attending to them too. And he says this handover period lasted about 30 minutes, which is an extraordinary length of time, as far as I'm concerned. And he also said that some tasks would require him to work with Dr. Christopher Wood, so he's the SHO, and some would have been done on his own. And he says his tasks would have included speaking to nurses and seeing the neonatal babies. He says if there was nothing outstanding happening in the neonatal unit, he would be there by 10 to 10:30. He says that for the night he was called over at 10 o'clock, having been called over because baby E had blood in his vomit. Small amounts of blood, minuscule blood flecks, were spotted when the NG tube was brought out of baby E, he recalls. So minuscule flecks of blood. And we remember Darby Evans telling us that Lucy Letby was thrusting some kind of weapon down this baby's throat. I can tell you, if you did that to a 30-week baby, you would not get minuscule blood flecks. But according to his account, these were minuscule blood flecks. And it's necessary for the prosecution to downplay this scenario here. Very like with baby A, there was no change in the ECG at the time of the collapse, so the heart was fine. So therefore, Professor Kinsey's pumping blue blood theory wasn't the case. And here we have to minimise the first presentation of bleeding, because should something have been done at this stage? That's a big question. And the court is shown a note from Dr. Harkness from 10:10 on August 3rd, which said that he was asked to see BBE regarding gastric bleed and had a large, very slightly bile-stained aspirate 30 minutes ago. So there's an assumption. I mean, it was referred to as a mucky aspirate with slight bile staining, and it was discarded apparently by 2 nurses. Now, discarding aspirates is fairly regular in hospital, but unwise in this case. And then he notes a sudden large vomit of fresh blood and a 14 ml aspirate. His note says in sudden large vomit of fresh blood and 14 ml aspirate. The doctor is given the opportunity to look through his clinical notes and Lucy Letby's nursing notes from that shift to see the chronology of events that night. The court is now shown the 10:10 p.m. note. He says it is not clear from his note how much of the 14 ml aspirate contained fresh blood. So there we have again another example of terrible note keeping. He says the fresh blood was what he had witnessed, having been called over to see it. The court hears he did not see the child vomit, but saw the fresh blood as a product of it. He notes that BBE's blood pressure was very good. Well, again, we get to the problem of blood pressure in preterm neonates. So, different studies have shown that there's a significant discrepancy between invasive and non-invasive blood pressure readings in preterm neonates, particularly in the very early part, first 4 weeks of life. And the bias is least for mean blood pressure readings, but can be significant for diastolic and systolic readings. So that's how blood pressure is usually recorded, by the systolic and diastolic readings. So the systolic reading, the higher number is when the heart's beating, and the diastolic reading, the lower number, is when the heart's filling back up again. But that's how blood pressure is recorded. So non-invasive, which is, cuffs or whatever devices they're using, can have a large range of under and overestimation, and relying on these is problematic for guiding circulatory management, and that's just the bottom line. The accuracy of non-invasive measurements can vary depending on the birth weight and the gestational age, all of that stuff. So accurate blood pressure measurements are critical in these neonates, particularly in the preterms, and there's a real potential for variability and error in non-invasive readings. So again, this is situational awareness that we're talking about here, not necessarily semi-reliable data points. So the situation we have here is that we have a potential hematemesis, which is coffee grounds, aspirate a substantial amount, 16 mils. Now we have another bleed. We have another aspirate with blood in it, but we don't know how much. Also, we don't know how much is going into or remaining in the gut and not coming up. Dr. Harkness goes on then to note sudden large vomit of fresh blood and 14 mil aspirate. He isn't even sure how much of this is blood and how much of it is aspirate, but he knows that the baby has vomited. He relies on blood pressure, which was very good, but it may not have been. And the heart rate was normal and saturation rates were good with minimal oxygen support. The baby's still on oxygen, but we know that we can't really go by the saturation levels that well, and the heart rate as normal doesn't tell you anything about the stroke volume of the heart rate, just tells you the number of beats, but doesn't tell you anything else. But he goes on to say at that point in time, everything is fine, except for the blood and the aspirates, he tells the court. That's just like makes the bottom of my stomach fall out. Because when I was being trained, vomiting of blood, particularly in a baby, was never regarded as something that you would refer to as fine. And then he goes on about the pink, well perfused, the lungs clear, the abdomen soft and not distended. We know how useless those things were in what continued next. And then he writes gastrointestinal bleed, ? Cause. So just ? Cause. He tells the court that is a possible diagnosis for the bleeding and a plan of action with administration of antibiotics is made. Right. So it's not a possible diagnosis, it's just The baby is bleeding from the upper GI tract, probably the upper GI tract, because the blood is so red. And he doesn't know what's causing it. So that's not a diagnosis. But he's going to put the baby on antibiotics and ask for close observation. Dr. Hartnett says from his recollection, he does not believe he left the unit, as the bleed was something unusual in baby E, so he did not believe he went very far. For the 11 p.m. note, he says Letby called him into room 1, further GI blood loss and desaturation to 70% is noted, and a 13 ml blood-stained fluid from NG, nasogastric tube, on free drainage is noted. So the problem is very much ongoing and progressive. He says he remembers seeing fresh red blood in the tube with the contents of the stomach. He says the free drainage setup would have allowed the vomit to come out rather than go into the baby's lungs. Unfortunately, that is not always the case. He says the origin of the blood must have come from somewhere in the esophageal tract, down to the stomach. It rules out blood coming from the lungs. The saturates remain low in 100% oxygen. And Dr. Hartnett said because of baby E's condition, the oxygen requirement had gone up from minimal support. So we see what happens in the space of an hour, space of 2 hours, when you get these little clues and you don't act on them. And this is not blaming anybody. This is medicine. This is the world that you live in when you do that job. And I remember even as a younger doctor, the usual thing about worrying about whether people would laugh at me or criticize me for overreacting. And when you get to see more and more, you realize that there really isn't any such thing as an overreaction. It's a bit the same as the old saying, better to have it and not need it than need it and not have it. And then he carries on and he goes, baby E was still trying to breathe at this time. And the comment crying is added to the note. Dr. Hartnett says the child is still well enough to be awake enough and conscious to cry. All of that's just so irrelevant. He said just the note, crying would suggest it was a typical cry. And again, what's the point? Who cares about that? So he's writing down things like cry and he's reinterpreting them years later, but he doesn't write down any estimate or attempt to calculate how much of this was blood. But he's got now 2 examples of it and possibly a third example in the mucky aspirate, which would be old blood. So that mucky aspirate that came up and Letby came on to shift at 9 o'clock, whatever time around that time, was at least, I would argue, 2 hours old. So it occurred on the previous shift and not because she shoved some kind of sharp object down this baby's throat. So the plan of action was replace losses, getting fluids back in. But what fluids is he going to put back in? Because the baby's losing blood. So you're going to put fluids in, and what's that going to do? There's nothing in the fluid that's going to stop the baby losing blood. So strict fluid balance, the court hears, knowing how much to put back in. But again, you're just putting in fluids, you're not putting in anything else. Dr. Hartnett said he is planning to intubate baby E and do an X-ray to check baby E's lungs and abdomen to try and explain why the baby was deteriorating. And again, no fault to Dr. Hartnett. A 3, 4, 5 year registrar in a neonatal unit should not be making these decisions on their own. Sorry, they should not. You need a bucket load of experience to deal with stuff like this. And then he goes on to say the type of intubation was elective, which was not on the level of an emergency situation, the court hears, but this is very much an emergency situation. Dr. Hartnett said he would discuss the results of the X-ray with surgeons at Alderhay and seek advice from them. But how long is all that going to take? I mean, it's taking 1 hour between bleeds that are visible. It's going to take at least an hour. We know that from BBA to get this X-ray and more to talk to people in Alderhay. Dr. Hartnett said he would have been preparing to intubate and getting equipment ready. Prescriptions are made from 11:30 for a number of drugs. A further note written in retrospect made at 1:45. There was a sudden deterioration at 11:40. Would it be any surprise to anybody who's been in a situation where they see anyone vomiting blood that there would be a sudden deterioration? No. When the stomach starts bleeding, it can leak like a sieve so fast. So he goes on to say that prior to that, BBE was still to be under close observation by Lucy Letby. Lucy Letby is a nurse who's doing observations and not making executive decisions about what to do in this catastrophic situation. Dr. Hartnett tells the court he was in the room when the sudden deterioration happened and was there with Lucy Letby and another nurse. Those nurses would have been gathering the drugs to be administered. So when their backs were turned, did Lucy Letby slip a bit of piano wire in there to get another bleed to come out? I think only Dr. Evans can answer that. The notes record a bradycardia of 80 to 90, SAT 60%, poor perfusion, colour change over abdomen, purple discoloured patches. So, poor perfusion, colour change over abdomen. But one of the big concerns here is a thing called DIC, disseminated intravascular coagulation, which can occur in babies with sepsis and with bleeding. So what is DIC? So DIC, the systemic activation of coagulation, leading to both thrombosis, which are the clot formation, and the hemorrhage. And critically, you get the consumption of all the clotting factors and platelets that are needed in these coagulation cascades and processes to stop bleeding. They get used up very, very fast. And this is again because of dysregulated activation of this system and because of tissue damage, particularly to the internal lining of tissue called the endothelium. And that again, as we explained, that starts the platelets, which starts the whole clotting cascade. And it's heavily associated with sepsis. And preterm neonates, unfortunately, again, are at higher risk of developing DIC. And particularly when they have sepsis, and particularly when they still need some kind of respiratory support, that the incidence of this would go up. And what does it appear like? I've seen DIC 5 or 6 times in kids and in adults. And the most important thing when you see this or you're concerned about this is to get blood tests, particularly one called a D-dimer, and look for what are called fibrin degradation products in the blood. And these are tests that can be done in a laboratory to tell you if the thing is present. You can have it with or without high or low platelet counts. So the fact that your platelet counts are normal does not mean you don't have DIC. But one of the things that you do see, and which I've seen in every one of the cases that I've seen, is skin discoloration. And in the cases I've seen, They were all on the abdomen. That's in general a thing called purpura. Purpura just simply means bleeding. So you're bleeding into the microvasculature of the skin. And if they're small, if they're less than 2 millimeters in diameter by definition, they're pinpoint hemorrhages and they're called petechiae. And these are the ones that parents are advised to look out for meningococcal disease. Between 2 millimeters and 1 centimeter, they're called purpura. And if they're bigger than that, they're called ecchymosis. And ecchymosis is what you would see when you see purple discoloration across the abdomen of a neonate who is actively bleeding. So this is terrifying stuff when you're actually witnessing it. And so the note of poor perfusion is another explanation for the purple discoloration of the abdomen. So I think, again, it just blows this whole our embolism thing out of the window. To me, it's just utter nonsense anyway. That's my medical opinion for what it's worth. And then he goes on to say, this was a strange pattern over the tummy and abdomen, but he doesn't use terms like petechia, ecchymosis, purpura, and there's a really, really easy way to find out, because the difference between the purpura and the discolorations is that when you apply pressure, that's the glass test, when you apply pressure to the purple coloration, it doesn't disappear under the pressure because it's bleeding under the skin. And he goes on to say, which didn't fit with poor perfusion. The rest was still pink, but there were these strange purple patches. Yeah, there were. And I would say that they were, depending on the size, petechiae, purpura, or ecchymosis. Unless we have any evidence to the contrary, that's part of the differential diagnosis, which fits better with the situation where a baby is bleeding than somebody injected air into a vein. He says some of the patches were still pink, but others were purple, blue, that were unusual. And he likens the purple-blue colour to what you would see after going for a swim in cold water and coming out, with purple-blue colour on the lips, which is mottling. And the rest of the skin was a normal colour. So, I mean, the abdomen had purple patches, which didn't fit with an anatomical part of the body. Don't know what that means. He says it is difficult to describe in any detail without a photograph. No, it's either blanching or non-blanching, in which case it's either purpura or it's not. He says that he's seen this in baby A before, and he'd not seen it in any other babies outside of this case. The patches were different sizes, and in the region of 1 to 2 centimetres, big, not dots. So there we are, ecchymosis. Considerable disseminated intravascular coagulation. The areas were on the abdomen, not above the chest or below the groin. They were in the middle section. And that is actually a physical sign described in the old-fashioned type of medicine that I learned. It's called Cullen's sign. And I will give you a photograph of Cullen's sign and preterm neonate in the show notes. And it is associated with, usually with obstruction of the gut, but it can be associated with other bleeding problems in the gut. And he goes on to say the patches did not fit with the perfusion seen. You're on 100% oxygen, so perfusion may not be the problem, but you're describing 1 to 2 centimetre big purple dots of different sizes, so you've got all 3 brands of purpura. He tells the court if the abdomen was dusky and white, then the whole of the body would gradually take that colour too. He says the case of an affected blood supply the blood would first be lost from the legs, and the body would pull the blood into the middle of the body. So again, he's just describing the mechanism of compensated shock, which can occur for any reason. But on this occasion, it is the middle where you're seeing these discolorations, which is frequently what happens with DIC. Yes, Dr. Harkness says so. This is the prosecutor prompting him. So I'll leave the link to all this. He's put on a ventilator a bit too late, in my opinion, but that's just my opinion. And then we'll get on to Ben Myers and see if he can get anything out. So Mr. Myers asks about the sequence of events. He refers to a police statement Dr. Harkness made, where the doctor says, "I was asked to review BBE by Letby following the finding of a dirty aspirate." So that's what he said in the police statement, a dirty aspirate. So he used the word dirty aspirate, and she used the word mucky aspirate. I would use the word possible coffee grounds. Looking at the notes, it was 10 to 10:30. I only came on at 9, so he's not even sure when he was in the ward. It was 10 to 10:30. What's in half an hour? What's in an hour? He describes in the statement the aspirate was largely mucousy. He said he could not be sure if there was a fleck of blood around BBE's face on examination. BBE looked relatively settled, and there was nothing to suggest that the situation was going to change. Sadly, there never is, or when there is, it's usually very subtle. He adds, however, around half an hour to an hour later, so again, what's in half an hour or an hour later, there was a large amount of fluid which came up the tube. From memory, it was 12 to 14 mils of blood, which for a baby was a substantial amount. Mr. Myers asks about the initial stages from the first clinical note at 10:10. Dr. Harkness confirms that he has been asked to review BBE following the bile-stained aspirate 30 minutes ago. So, before 9 o'clock, he was asked to see the baby. And he refers to it as a bile-stained aspirate, but he referred to it in the police station as a dirty aspirate. And again, it's just, why will these people not use medical language, you know? Dr. Myers said all of that happened in the 10:10 note. That had happened by 10:10. Dr. Harkness said that this was a 40-minute period of several years ago. He said this was potentially a period of 9:30 to 10:10. He said it would match up with the note. So Dr. Harkness gets licensed to be vague about times, but Lucy Letby doesn't. So he's talking, it could have been 9:30. He doesn't know. In the police statement, Dr. Harkness said he would have been bleeped by Lucy Letby. So he told the police he was bleeped by Lucy Letby. He says that would have been the most common approach to be alerted by Nursery Room 1. That how else are you going to get him? You don't know where he is. He said he had seen a dirty aspirate which may have contained blood flecks and bile. Mr. Myers said the police statement said BBE had nothing dramatic around the baby's face and could not be sure if there was any blood flecks. BBE was not in distress and appeared fine. Dr. Harkness says he does not know if he saw BBE's mother and does not have a clear recollection. He says it could be the case looking at the notes provided. So we really have two different stories going on here, but we have the fact of the baby bleeding. That's the only fact that we really have here. And we have the possibility of disseminated intravascular coagulation as an explanation for the skin discoloration along with the concomitant shock. Mr. Myers asked if Dr. Harkness had any particular concerns. From the first reading, Dr. Harkness says there wasn't. He agrees the second note, the blood vomit, was more concerning and suggested a gastrointestinal bleed. And Mr. Myers asked if such a bleed was serious. And Dr. Harkness replies, potentially, when the answer is yes. Mr. Myers suggests that a GI bleed should have led to a blood transfusion. Well, he's jumping the gun a bit, but I see where he's going. Dr. Harkness says if there were other observations which collated that, he would have done so, but at this point, he would not have done so, as the blood vomit could have had other causes. What difference did that make to the decision whether to blood transfusion or not? So what we're going to do is wait until we see more bleeding. I don't understand that. He said a blood transfusion may have come up in a conversation with a fellow doctor. Mr. Myers asked why that wasn't documented, and Dr. Harkness says he cannot answer that. So again, it's okay that Dr. Harkness can't answer questions, but it's not okay that Lucy Letby can't answer questions. Equal justice under the law. The clinical note for 11 p.m. is shown to the court, which the court hears refers to a large amount of fresh blood. And you can't get clearer than that, can you? Dr. Harkness was called to the unit. The 13 ml blood-stained fluid is a significant quantity, Dr. Harkness confirms. Mr. Myers said this follows other bloods which came out earlier, and a typical baby would have had something in the region of 120 mils of him in at that time. So this is 120 mils made less important by Dr. Kinsey's 142 mils, but again, they're all just estimates. And Dr. Harkness agrees. Mr. Myers says that there's been 27 mils of blood and aspirin taken from him at that time, which was up to a quarter of baby E's blood. And Dr. Harkness agrees, even though he said he couldn't be sure how much blood was in it. He's now agreed that there was that much blood. Mr. Myers says the heart rate is normal, but the saturation rate is low. He says the heart rate should be higher. Dr. Harkness says not necessarily. There are multi-factors to that. It's part of a separate conversation with expert witnesses. I have no idea what he's talking about. You've got the onset of hypovolemia, almost certainly that's low blood volume. You have active bleeding, you've got low saturations, and the heart rate should be higher, but it wouldn't necessarily be higher. So they get into this discussion then about the saturation pairing with the heart rate. And again, you just read it, but if you listen to some of the other podcasts, I explain why that's not necessarily the case. It's a thing called decoupling, and it's all of this compensation, decompensation stuff that's all very complex and not predictable. Mr. Myers asked why a consultation with surgeons was required. It's also irrelevant because we know the baby has lost a quarter of his blood volume, so we have to act. We have to act. Dr. Harkness says advice would have been taken from them once the X-ray results would have been acquired from the X-rays. Mr. Myers says he could have been dealing with a very serious situation indeed. And Dr. Harkness, minimising again, says, potentially. Dr. Harkness says things were changing, but baby E was still stable. So a baby who's lost quarter of his blood volume and 100% oxygen is still stable. Mr. Myers, are you suggesting that a baby who has lost a quarter of his blood volume is not an emergency situation? Dr. Hartness, what I'm suggesting is there are things to do and there is time to do it. Well, let's see what things he did then. Mr. Myers said transfusion was not being considered at this point, and one of the obvious things to consider was transfusion. It is something you have failed to consider, isn't it? Dr. Hartness says it was likely considered, but accepts it was not documented at the 11 p.m. note. So it was likely considered. Mr. Myers suggests it was a serious mistake not to consider blood transfusion, and Dr. Hartness said, I disagree. And I'll leave you, as an ordinary citizen, to think whether you think somebody who loses a quarter of their blood volume, whether they're an adult, but particularly if they're a preterm neonate, would be a candidate for a blood transfusion. And don't forget, blood transfusion takes many forms. So there's whole blood products, fresh frozen plasma, packed red cells, platelets. But you need to be getting on with it. All of those things have to be prepared. When I was dealing with gunshot wounds and penetrating injuries in the north of Ireland, one of the biggest failings we had was blood transfusion, quantities of blood transfusion. And until that got really sorted out, which took a huge amount of effort, we never got anywhere. And I do recall one young soldier who I hope is still alive and well because he was younger than me at the time. And he required 120 units of blood in various parts. So fresh frozen plasma, spun platelets and blood. And that's how much went in and went out of him while he underwent a 16-hour operation. So when he came in, he was still talking. He was very pale. He was still talking. And I remember going over to them with the anaesthetist, and the anaesthetist taking his hand and telling him he was going to be okay, but he had to put him to sleep and not to worry. I remember it well, but I do remember the vast quantities of blood that we needed. Dr. Hartness disagrees that it was a serious mistake not to consider blood transfusion. Mr. Myers asked about the staffing levels that night and asked what would have happened if Dr. Hartness had been called to the A&E department, and Dr. Hartness said he would have contacted the on-call consultant at the time to come over in that instance. Mr. Myers, I would suggest you were out of your depths at this point. And Dr. Hartness says, I disagree. And I can tell you, there's absolutely nothing wrong with being out of your depth in medicine. My God. It's like being under an artillery barrage sometimes. You're pretty much out of your depth. So what do? You call for help. You call for help. And again, we have another episode in this hospital, the never-ending tale of young doctors, junior doctors, still in training, failing to escalate. So whether or not he considered a blood transfusion the right thing to do, elective intubation and secure the airway the right thing to do, whether he agreed with that or disagreed with that, that should have been decisions that were taken at a much higher level. but so far he hasn't called anyone. And then Dr. Hartnett says, that is wrong and disrespectful to my ability. No, it's not. Being out of your depth has got nothing to do with your ability. It's to do with the circumstance and your situational awareness. That's all it's got to do with. Mr. Myers says blood transfusion is not considered. So he's hammering this home. But we do have a plan, and we do have a discussion with a consultant. But what use is a plan? And anyway, we all know the old saying about a plan doesn't survive the first contact with the enemy. Mr. Myers said the intubation should have happened earlier. Again, it's a matter of opinion, but should have had another medical opinion there. Dr. Hartnett says there are benefits to an elective intubation compared to an emergency intubation, as the latter could cause stress and complications to the baby. So I don't know whether he's agreeing or disagreeing here, but again, it's not something that a lawyer can really argue on his own. He said that now, this would still have been the course to take in that situation. You can make about what you will. The court hears the preparations are made for the intubation during a half hour. Dr. Harkness disagrees with Mr. Myers that it was a delay and was using his time appropriately. But he was still acting on his own. He was still acting without notifying somebody more senior and getting another set of hands in there. You make more mistakes when you're not taking your time. Yeah, possibly, but when you're experienced, that doesn't tend to be the case. And anyway, the bleeding is not interested in your time. Mr. Myers says the blood transfusion is mentioned for the first time in a later note after 11:40 p.m. Dr. Hartnett said it would not have been appropriate to give more saline boluses without administering fresh blood. So the saline boluses are used to expand the blood volume, but they will not have any impact on oxygenation of the red blood cells or extra provision of platelets or coagulation factors. It will have no impact on that at all. The saline boluses would have been absolutely appropriate, but there should have been, in my humble opinion, the anticipation that blood and or blood products would be needed. He disagrees a blood transfusion was not considered earlier. Whether it was considered earlier or not, it wasn't done earlier and preparations were not made for it. He says his documentation is not as thorough as it would be now, and agrees in hindsight it should have been documented more clearly. But like the rashes and the skin discolorations, we don't really need to document it because the jury's going to believe us. And we get inevitably to the skin discoloration observed is noted and that it later remained on the abdomen. A nursing colleague had referred to discoloured abdomen in a retrospective note written at 1:30 a.m. Mr. Myers said Dr. Hartnett had referred to discoloration being strange and unusual and appearing and disappearing. That does not appear in the medical note, Mr. Myers said, and we've heard that before. Dr. Hartnett said that observation has stayed with him, and the clinical note he made at the time was not forensic. That's the second time he's used that excuse for poor note taking. So he wasn't practicing forensic medicine at the time. He was practicing clinical medicine, doing appearance of the skin, very much the biggest organ in the body, is very much part of a clinical description. Mr. Myers reads out part of Dr. Hartnett's statement to the police, referring to the discoloration being on the abdomen. Dr. Hartnett said does not recall the part of the statement of the discolorations pass to the body, and said he would not agree with the wording of that. So he doesn't agree with his own police statement. He says that he has not been in discussion with anyone in relation to these observations. Mr. Myers said by October 2018, by the time of this police statement, there had been discussions in the hospital about the skin discolorations. Dr. Hartnett said there were discussions to say it was unusual, but refutes any of the details of the discoloration had been discussed. So maybe somebody will let me know how people can have a discussion about something that is unusual without describing it. Mr. Myers says Dr. Hartnett is putting details together from various observations, and Dr. Hartnett says no, even though he disagrees with his own police statement. Mr. Myers says baby head skin discoloration, as referred to by Dr. Hartnett in court earlier in the trial, were not mentioned in the clinical note at the time or the note to the coroner. Mr. Myers says red patches found on baby A were not mentioned for baby E. Dr. Hartnett says the overall discoloration observations were similar enough. And again, you make your mind up. Mr. Myers refers to baby E's collapse in front of the medical staff. He says at this point there still had been no transfusion. Dr. Hartnett says there were no further evidence of bleeding after the second bleed, but we've just had further evidence of the bleeding. And if we have possible DIC on the abdomen, we know for a fact we're going to get more bleeding, and that there's even bleeding going on that we can't see. Mr. Myers, the reaction to the second hemorrhage was far too slow, wasn't it? And for me, I think that's the clincher. I mean, I don't think anybody is going to criticize you for escalating with a second hemorrhage. But Dr. Hartnett disagrees again. Mr. Myers said a blood transfusion for O-negative blood is noted at 12:50 a.m. on the medical notes. Dr. Hartnett says the O-negative blood, a type which is suitable for all blood transfusions, would be used in this instance as seeking a specifically matched blood type at this stage would take too long in acquiring it from the donor fridge. So I rest my case. The minute you know a bleeder is coming in, you get the blood guys on the phone. The note of 12:36 a.m. CPR commence is mentioned. The transfusion would have followed. And then he goes through the stress in detail, which is not necessary. And Mr. Myers says the cause of death would be acute blood loss. So that's the mechanism of death, like sanguination, not the cause of death. Dr. Hartnett said that cannot be known without a post-mortem examination. So if we want to fully exonerate Dr. Hartnett for any errors in judgment or actions, I think he's absolutely right. But the same should apply to Lucy Letby. No post-mortem, no proof. He said the blood loss could be a factor, but it is not black and white. No, it's red, and you do not want to see it. He said it was not his place to call for a post-mortem examination. Mr. Myers said the blood loss seen would normally be fatal, and Dr. Hartnett said it could be linked. So there you go, lads. Go down to the blood transfusion service and tell them that you'll give them a quarter of your blood volume and see what they tell you. Mr. Myers asks if the actions taken were far too slow, and Dr. Hartness says no. Would you have admitted it if it was? And Dr. Hartness says yes. And then we get pop-up prosecutor. Again, he rises about the timing of Dr. Hartness's meeting with mother of child E. Dr. Hartness said that would have been the case based on a nursing note. The prosecution asks if that was from looking at Letby's note, and Dr. Hartness agrees. The prosecution says Dr. Hartness's clinical note does not refer to a meeting with the family. Dr. Hartness said it could be documented, but would depend on the level of detail in the discussion. I don't know. Dr. Hartness' interview with police in September 2018 is relayed to the court. Dr. Hartness is asked about skin discoloration, and he said it is similar between baby A and E and is not a rash. The interview transcript says baby E's discoloration was around the abdomen and chest with purple patches and suddenly come on. It came so quickly, not affected by the monitors or anything. All the more reason it was disseminated into vascular coagulation. It was just purple and pale patches, purpura, ecchymosis, petechiae, DIC. He was asked in the police interview if that was symptomatic of other cases, and Dr. Hartness said that was not. So there we go. So we're going to end this history. There's a lot of other information in here. I would advise people to read through it. People saying that baby E was never a good feeder, no progression of the feeding, needing oxygen up and down, even in air. Like now restarted on antibiotics after bleeding, even though they were stopped after 3 days. There's so much stuff in here that should have had another medical opinion. And as I say, I hope now that Mark MacDonald is now the counsel for Lucy Letby, that those of us who are concerned about the care of babies and mothers, and about justice, and about the incredible work and stressful work that nurses do, and how badly they are being treated at the minute. Those of us who care about all of those things hope that Mark MacDonald can get more answers. And in the next episode, we're going to move on to case 6, which is baby F, the twin of baby E, and the attempted murder allegation of insulin poisoning. So I'll see you in the next episode. Bye.